here for this PPD training. Yes, as medical laboratory scientists, we find ourselves in a very special place where we have to play a very important role when it comes to patient care and patient management in general. And we are all aware that our role is in the area of diagnosis. And so patients may present with various conditions, or they may present with various signs and symptoms. But then we know that various disease conditions may mimic all these signs and symptoms. So it's difficult to tell which of them exactly is causing what the patient is experiencing. And for that matter, we become very important when it comes to providing that support to enable the clinician to be able to know exactly what to do with respect to a patient's condition. Now, every mammal, and even other organisms which are not found within the kingdom Animalia may also share what humans share, in the sense that we have something that runs through our body that helps us to be able to thrive or to support all metabolic processes that go on in us. And I'm specifically referring to blood. So in the lab, we realized that hematology and investigations on hematology happen to contribute or to form a very major proportion of investigations that are requested by clinicians. And so one very important part of blood is the cell we call erythrocytes, or red blood cell. Now, this cell is so important in the sense that it helps to transport oxygen to our tissues from the lungs, and also helps to expel carbon dioxide back to through the lungs and then into the atmosphere. Now, to enable this cell to play its role, it needs to, present with specific characteristics that can help it to provide these particular services in an optimal way for the individual. So at any point in time, if these particular services are not provided as expected, then the patient will start to, experience some things that would point to the fact that there's something that has gone wrong. And so today we want to look at morphological deviations of erythrocytes. So if we say morphological deviations, what we mean is that red cells have a structure. They have a structure, an anatomical structure. And with this anatomical structure also goes physiological roles or physiological functions. And so if for any reason you have a shift or a deviation from this anatomical structure, or what is expected to be normal of this anatomical structure of the red cell, then the patient may, or the individual will not experience optimal health. So here we are going to look at the etiology. If we say etiology, we are looking at the cause or the origin of these deviations, how they come by. And then also, what impact do these deviations bring to the individual, and how does it affect health in general? So that's going to be our focus for today. So once again, I'm Emmanuel Allottey. So we'll start this presentation by looking at some facts about red blood cells. So first and foremost, we need to be aware of the fact that if we are talking about a red blood cell, it is a specialized cell. It is a specialized cell. It's just like the way you start your education from primary school to junior high school to senior high school, then to the university or to the polytechnic or technical university, whichever way it is. And the thing is that if you have a newborn child or a child who is quite, just a few days old, not even yet toddling, and not to talk about walking, and then you decide to send this child into the hospital lab, and you expect this child to be able to perform anything that a trained medical laboratory scientist is supposed to perform, he or she will not be able to. In the same way, if you take a primary school child or a junior high school child or a senior high school child, they will still not be able to perform these roles because they have not yet been trained or they've not undergone the full training to be able to carry out these functions. And so, as medical laboratory scientists, we have specialized or we have tried to, learn a particular profession because you realize that you started school with different people and everyone has gone into a different kind of profession, and that is specialization. So the red cell, first and foremost, is a specialized functional cell, and the site of production is the bone marrow. The bone marrow is found in all our bones. So that's why it is a marrow, but then classified as being or qualified as a bone marrow, telling you the source. Now, within the bone marrow, there is a very primitive cell, which we call the hematopoietic stem cell. So it is out of this hematopoietic stem cell that red cells are derived. Now, from the primitive cell all the way to a specialized red cell or a mature red cell, various hormones come to play or they help through these processes. So one can say that we can compare these hormones or these factors that enable the red cell to develop to be like the teachers. Because primary school, you have a teacher, JHS, SHS, someone will be guiding you, guiding your growth and development until you now get fully trained. So we have examples being the stem cell factor, interleukin-3, granulocyte, monocyte, colony stimulating factor. These are all factors that help in the development of the red cell. But then the chief hormone that helps with the development of the red cell is erythropoietin. So this is the hormone that will now start the final training of the red cell or will help the red cell to move on the path that it will now become what we know as the red cell. So without this erythropoietin, there will be no red cell formation. There will be no red cell formation. Now, red cells are so important in their function to the body such that the body produces red cells at a rate of 2.3, or let's say 2.3 million. Yes, 2.3 million of them are produced per second, or they are released per second from the bone marrow. Now, red cells are not without pathologies or without disease conditions. Just like as normal human beings, we also suffer from various diseases, or we have various challenges we face. Red cells also are not left out as cells within the body. So the chief pathology of a red cell is what we call anemia. And anemia may simply refer to a reduction in the hemoglobin level of that individual, but usually would arise as a result of a decreased production of the red cells or an increased destruction of the red cells, or both of these processes can be occurring. And then we also have polycythemia. In this case, we have an increased production of the red cells. So be it anemia or polycythemia, it's not going to augur well for the patient. So here we just take a very quick look at the production of red cells. So we call this process erythropoiesis. So the PSC, as we have here, let me use the pointer. Yes, so the PSC as we have here is referring to the pluripotent stem cell, referring to the hematopoietic stem cell. And this develops into another primitive or a less primitive cell called the colony-forming unit, granulocytes, erythroid monocytes, megakaryocytes. So this cell actually has a potential to form granulocytes, to form red cells, to form monocytes, to form platelets. However, upon the action of erythropoietin from this level, this cell can now differentiate and commit to the path that will lead to the formation of red cells. So um, the first primitive cell that can be said to be on the trail to become a red cell is what we call the bast-forming unit erythroid. And this also further develops to form what we call the colony-forming unit erythroid. And this further produces what we call the pronormoblast. Now, the pronormoblast happens to be the earliest morphologically recognizable form of a red cell within the bone marrow space. So that is to say, the PSC, CFUGM, and BFUE, CFUE are all not recognizable in the bone marrow space. You cannot pinpoint them and say that this is this particular cell. So the only recognizable form, earliest recognizable form or primitive form of the red cell is what we call the pronormoblast. And out of the pronormoblast develops the normoblast, and then out of the normoblast also develops what we call the reticulocytes. We'll talk a little bit more about this reticulocytes as we go on. Then from the reticulocytes, you form the matured red cell. So here in this picture, we have some of these primitive cells and at different developmental stages until you form the mature red cell. So this is actually a picture from within the bone marrow. However, in the background, you can still see some matured red cells in the background amidst the presence of all these immature ones. So one important thing for us to note is that the matured red cell does not have a nucleus. However, the primitive cells out of which the red cell develops all contain nuclei. They have nucleus. Okay. However, it is at a certain stage of development of the red cell that the nucleus gets extruded. And it is extruded for a purpose, because with the presence of the nucleus, it means that the red cell would not be fully functional. And the red cell would not also be able to successfully go through the various blood vessels, especially when it has to go through tiny blood vessels. If you still have the nucleus in there, it is going to get the red cell to get stuck when trying to go through smaller blood vessels, because the red cell has a special property of being able to fold itself. So if the red cell comes to a blood vessel that is smaller than its own diameter, it is capable of folding itself to become smaller and then squeezing itself through that blood vessel. And then once it is out to a larger vessel, it just pops out to its normal size and it moves on. So out of every pronormoblast that is formed within the bone marrow, 16 red blood cells arise. 16 red blood cells arise out of a single pronormoblast. So this picture here shows us from where a pronormoblast is formed. So cells within the bone marrow divide by a process we call mitosis. And so here you have the pronormoblast divided into two other cells. Then these as well go on and also keep on dividing. So you just keep on having the division into two, into two, into two, until you get to the last nucleated stage of the red cell, which we call the autochromic normoblast. So it is at this stage that the red cell nucleus gets extruded, and then you form the reticulocyte. Now, if you look carefully, the reticulocyte is a red cell, not fully matured, but then it has some, you can see some blue stains inside it. Those blue stains are referring to the reticulin fibers that are formed or that are found within the reticulocyte. And it's actually the reason why we call them so. Reticulin fibers in those red cells is why we call them reticulocytes. That's how their name was coined. So these reticulocytes also have a very important diagnostic value, which we'll talk about a little later. So these reticulocytes now mature. They don't divide anymore. It's only the nucleated levels of the red cells that divide. But at the reticulocytes, there is no nucleus, and so there's no further division of the red cell. So here you have the matured red cell. But however, you see that Within the red cell, you see a certain hollow. We'll talk about this hollow as we move on. Now, the reticulocyte count is important when it comes to diagnosis and monitoring of a patient's condition. Here, it is used to assess the appropriateness of the bone marrow's response to anemia. So when there's anemia, there's a reduced red cell count, there's a reduced hemoglobin, the bone marrow tries to, produce and to release more red cells. And so when you're able to assess the number of reticulocytes in the blood, it gives you an idea as to the health of the bone marrow, as in telling you that is a bone marrow capable of, correcting the anemia? Is it capable of, bringing in new red cells to replace the lost ones? So that is the reticulocyte count. So the red cell is biconcave disc, meaning that it has a curvature on both sides. Okay, so that's why we say it is biconcave. And then it has a diameter of 6 to 8 microns, and then a volume of about 90 femtoliters. So this is also usually a range. And that is what we measure and call the mean cell volume. So this is just a picture showing us how the normal red cells look like. And then also in terms of the diameter, that's if you take it on the width and then on the lengthwise. So 8 microns in diameter, and then to the width about 2 microns. So when the red cell is folding itself, yes, it can fold itself to about 2 microns. And usually the smallest blood vessels may be about 3 microns in diameter. So the red cell, with being in its correct structure and shape, is able to squeeze itself, become small enough to go through blood vessels, which are about 3 micrometers in diameter. So, like I mentioned earlier, the matured red cell has no nucleus. Rather, in the place of the nucleus, or in the center of the red cell, there is this hollow, which we call the pallor. And that pallor, under normal circumstances, is supposed to occupy about 1/3 the diameter of the red cell. And the rest of the space within the red cell is filled with hemoglobin. Hemoglobin happens to be the major protein, cytoplasmic protein, that is found in the red cell. And you have about 480 million copies of hemoglobin per red cell. And they are that many to tell you that they have a very, very, very important role to play. And that's how come the red cell has to produce that much. So over here, we see cells with the hollow in the middle. And so when you are looking for a cell to describe the hemoglobinization, you check it by looking at the hollow, the size of the hollow. If the size of the hollow is 1/3 the diameter or less than 1/3, we'll say that that red cell is normochromic, meaning that it has a normal staining of hemoglobin, actually correlating to how much hemoglobin is within the red cell. So when you are totally healthy, or for a healthy person, there are slight or little variations that you will come across in terms of the size of the red cell and then the shape of the red cell. But in disease conditions, these variations become more pronounced. So most of the red cells that we will find in any blood film, they will be found to be round, have smooth contours, and have a diameter of about the 6 to 8 microns. However, you might have a small proportion, usually maybe less than 10%, that may be oval in shape instead of being round. And then there are some too that may appear a bit contracted, or the contours are not regular. And those would usually be less than 1%. But then this is acceptable in a healthy person. However, one very important thing which is crucial when it comes to diagnosis of anemia and to also know how the bone marrow is faring or is responding to the anemia is the reticulocyte response or the reticulocyte count. So when there is anemia and you examine a blood film, the blood film may either point to one or two things, especially when it is referring to the loss or the anemia is as a result of loss of red cells. So red cells can be lost either through bleeding or through hemolysis. So when you have an anemia and there is an appropriate reticulocyte response, meaning that if you do the count of reticulocytes, the counts are normal. But then this can be established in the absence of bleeding. That would mean that the patient is undergoing hemolysis. In the blood film, when there is bleeding, some features within the blood film would give you a clue that the patient may be undergoing bleeding. And if there is hemolysis too, there'll be signs you would see in the blood film that will tell you that the patient is hemolyzing. And so if there's an appropriate reticulocyte response and you can rule bleeding out, that means that the cause of the anemia is likely to be hemolysis. Now, hemolysis is a very wide thing in terms of the breadth, the contents or the breadth we cover when we are talking about hemolysis. But it simply means, premature breakdown or premature destruction of the red cell. We'll just take it at this level that hemolysis simply means premature breakdown of the red cell. So this is a blood film of a healthy adult. Now, a lot of times we need to describe the morphology of the red cells. We need to say something about the size. We need to say something about the hemoglobinization. We need to say something about the shape of the red cell. And so usually when it comes to the size of the red cell, if we want to have an idea what the normal size of the red cell is, we look out for a small lymphocyte. So we usually look at the size of the nucleus of a small lymphocyte, and we assume that for that individual, the normal size red cell should be as large as the nucleus of a small lymphocyte. And so if you look at the sizes and they are smaller than the size of the small lymphocytes, the nucleus of the small lymphocyte, then you see that those cells are microcytic, meaning that the sizes are below the normal that is expected. And then in the event where you meet red cells whose sizes are much bigger or larger than the nucleus of the lymphocytes, we will say that those cells are macrocytic. And let's also note one thing, that there would not always be an agreement between what the full blood count tells you and what you actually see from a blood film. And so we should not, the full blood count is just to guide us when we need to do some of these morphological descriptions of red cells. However, the film will tell you what is really true. The full blood count analyzer runs on principles, and sometimes whatever is happening in that individual may come with so many things that the analyzer itself gets a bit confused and it cannot tell what is what. However, with your training, you should be able to look at a blood film and say that, okay, it looks like this is what is really happening. So what would cause red cells to have abnormal morphologies? So there are four main causes. So the first one is when you have an abnormal erythropoiesis. Abnormal erythropoiesis here can refer to the rate of erythropoiesis. Either erythropoiesis is becoming faster than normal or it is becoming slower than normal. or it could also refer to the structure of the quality of the cells which are being produced. So if the quality is not there, the rate of production of the red cells is also deranged. Yes, that can lead to you getting certain red blood cell abnormalities. Then another one too is when you have inadequate synthesis of hemoglobin. Inadequate synthesis of hemoglobin. Third is when you have a damage to the red cell after it has left the bone marrow. So from the bone marrow, the red cell was produced normally, it has normal structure, everything was fine. But after it left the bone marrow space into the bloodstream, something happened to the red cell on its journey. And that could also cause the red cell morphologies to change. Now, if we get to know, the red blood cell over its 90 to 120 days lifespan, it travels a total of about 480 kilometers in the body. During the 90 to 120 days, it travels about 480 kilometers. And then lastly, in the attempts by the bone marrow to compensate for anemia by increasing erythropoiesis, the red cell may undergo some morphological changes or will present with morphological abnormalities. So anytime you see a deviation of the normal shape, normal hemoglobinization, size of the red cell, it tells you that one of these four things may be happening. And so you put on your diagnostic lenses, you put on your investigative lenses to find out exactly what is causing these things to happen. All right. So with the four things that we did mention, it's going to result in something we call anisocytosis. Anisocytosis here means that you are going to have red cells that vary in their sizes. Another thing that could happen is poikilocytosis, in which case the red cells will vary in their shape. There'll be a deviation from the normal biconcave dish shape. Another thing too is what we call punctate basophilia or basophilic stippling, which in this case, within the red cell space, you find some granules which stain basophilic or which stain bluish. We know that within the red cell cytoplasm, you expect hemoglobin among other proteins, but not any other foreign body. But in this case, you may find these basophilic granules within the red cell. Another thing that is likely to happen as a result of the abnormal erythropoiesis is dimorphism. Dimorphism here means that having two distinct populations of red cells. So these red cells could vary in their sizes and in their hemoglobinization. You see two clear populations. Red cells should have an almost uniform size and shape. But in this case, you are going to have populations of red cells which may vary in size or they may vary in terms of their shape or their hemoglobinization. So now, the other abnormalities that we are going to see, like I would say, may affect the size of the red cell. So if the red cells are small in size, we say they are microcytes. If they are big in size, we say they are macrocytes. And if the shapes are also, the sizes are varying, we say that's anisocytosis. And then we have changes that occur that affect the hemoglobinization. So if the amount of hemoglobin is low within the red cell, we say that is hypochromia. Or if you are describing a single red cell, you might say hypochromic. The red cell is hypochromic. If the amount of hemoglobin is also so much such that the central pallor is missing. We call that hyperchromia. Then we also have anisochromia or anisochromasia. And that is when you have, red cells within the blood film having different amounts of hemoglobin. So you might see a red cell that looks hypochromic, a red cell that looks normochromic, a red cell that looks hyperchromic, all for just one patient, all found in one patient. So that's anisochromasia. Then we have polychromasia, in which case the staining of the hemoglobin becomes a little bit different. It stains a bit bluish. Instead of staining pink, it starts to stain a bit bluish, and that is polychromasia. Another abnormality that we are likely to come across will be variation in the shape of the red cells, and we call those poikilocytes. So if you find any red cell at all whose size is is way from what is expected, that is simply a poikilocyte. So examples include echinocytes, which are also known as bear cells. You have acanthocytes, you have schistocytes, sickle cells, you have stomatocytes, pherocytes, elliptocytes, or ovalocytes. They are both not the same though, but because they are usually as a result of the same kind of abnormalities, that's why I put them side by side here. Then you have pencil cells. You also have teardrop cells, and then you also have target cells. Now, a target cell here, I put the asterisk by it because a lot of times when we see target cells, due to the way they appear, we assume that it's a problem of hemoglobinization. But the target cell is not an issue of hemoglobinization. It's about the shape of the red cell. So it is only when you use an electron microscope to take the picture of a target cell that you realize that it is actually a poikilocyte. However, that poikilocyte, upon staining or following staining, that it appears the way we see it in a blood film and we call a target cell. So we'll take time and go to each of these abnormal shapes and sizes and then see exactly what brings or what causes those to happen. So we start with looking at changes in size or size variation. Here in this picture, we can see a smallish man, and then we can see a very tall and huge man here. So first of all, look at anisocytosis. Anisocytosis. Here, the red cells are having varying sizes. Clearly from the blood film here, we can see that this is a small cell. So we have the nucleus of a lymphocyte, just to be a guide to us being able to judge whether a red cell is microcytic or normocytic or macrocytic. Then over here, we have some red cells too, which look normal in size, although the shape, there are many things to this film though, but the reason why I'm showing it here is just to show us the difference in sizes. And then this red cell here looks quite larger than the size of the nucleus of this cell here. And so we may refer to that cell as a macrocyte. So you are having about 3 populations of cells in terms of the sizes. So there is a parameter in the full blood count report called the red cell distribution width, abbreviated as RDW. So anytime we have an increase in the variation of the red cell sizes, the RDW value also changes or it goes out of range. So we might find this happening in iron deficiency anemia, sickle cell anemia, the thalassemias, autoimmune hemolytic anemia, megaloblastic anemia, pernicious anemia. Then you even have congenital dyserythropoietic anemia, and then in myelofibrosis. So assuming you come across a film like this, there's anisocytosis. You need to look at other things from within the blood film and then from your full blood count. And we'll be carrying out other investigations to help you to know which of these conditions um, is making the patient to present with such a blood picture. And so maybe somewhere in the future, when we are having other sessions, we can take some of these particular topics and go into them a bit more detail. Now, the next is the microcytes. The microcytes. So here we are looking at red cells which are small in size, smaller than the size of the nucleus of um, a small lymphocyte. And in this case, we are having red cells whose volume is less than 80 femtoliters. And the main cause of, or the etiology of forming microcytes is when you have a defect in the hemoglobin production. So there is something impairing or impeding hemoglobin production. So the major differential diagnoses that are associated with microcytosis or a microcytic anemia are the thalassemias, the anemias, the thalassemia, and anemia of inflammation or chronic disease. You have iron deficiency anemia, which is very common worldwide. And in Ghana is the most common cause of microcytosis. And then you also have lead poisoning. So lead poisoning, for instance, if you look at the formation of hemoglobin, you would see points in the process of forming protoporphyrin. There are certain rates points at which time lead can actually, inhibit the conversion of some of the metabolites involved in the production of protoporphyrin. And so lead poisoning can also inhibit hemoglobin formation. And then you also have sideroblastic anemia. Sideroblastic anemia as the other, differential diagnosis that would lead you to produce microcytes. Then we have macrocytosis. Macrocytosis here, the red cell diameter is greater than 9 microns, and also in terms of the volume is greater than 100 femtoliters. And usually, if you come across macrocytes, they are likely to be either round or oval in shape. And the shape the macrocyte takes will lead you on to make other diagnoses. So one, if you have folate and vitamin B12 deficiency or both, you are most likely to have oval red cells, oval macrocytes. And then in the case of alcohol abuse, the red cells will usually look round. Then in the case of liver disease, the red cells will also look round. And then finally, if you have a situation where the bone marrow is compensating for anemia, and for that reason, it has released a lot of reticulocytes into the blood film, that one too would lead you to having round red cells, not just round red cells, but large in size, round macrocytic red cells in the blood film. So next, we also look at the hemoglobin in the red cell. The hemoglobin in the red cell. So like I did mention earlier, red cells with a normal size and a normal hemoglobinization have a pale area towards the middle of the red cell. And in this case, this pale area is supposed to cover about 1/3 the volume of the red cell space, cytoplasmic space. So if it is like that or lower, then we say that the red cell is normochromic. It's normochromic. All right. But in the case where you have inadequate hemoglobin formation or inadequate hemoglobin production, it will lead to, a reduced or unequal distribution of hemoglobin within the red cell. And so you end up having hypochromic red cells or anisochromasia. Hypochromic red cells or anisochromasia. In this case, some red cells may look hypochromic, others may look, either hyperchromic, and then, and so on and so forth. So you are having variation in the hemoglobinization of the red cell. So this is hypochromia. Looking at the red cells in this picture, we can see that the central pallor, or that pale area, is way beyond the 1/3. We can say that this one is even about 2/3 or more. And the hemoglobin is almost towards the ends of the membrane of the red cell. So this is hypochromia. And we see this in iron deficiency anemia, thalassemia, and then other severe chronic diseases. So this is anisochromasia. So we see the variable staining. Some of the red cells stain a bit hypochromic. Others also, this one, for instance, you could see that the hemoglobin is almost full within the blood film. This one also has adequate amounts. And then this red cell also seems to have enough hemoglobin inside it, and so on and so forth. So within this blood film, there are other pathologies here, but our focus is just on the anisochromasia. So sometimes this kind of change may indicate either a dual population of red cells. For example, when someone gets transfused, or someone probably having been diagnosed to have a nutritional deficiency, and the person is now put on some hematinics to correct the anemia. The person will tend to have, the red cell production becoming normal in the new cells that are being produced, while the old cells still are showing signs that they were the old cells. So the very hypochromic red cells would be the old cells, and then the new ones that have enough hemoglobin will be the new cells. So that would be a case of anisochromasia. Now, anytime the bone marrow tries to compensate for anemia by increasing production, this would present with, or the patient would tend to present or show a lot of less mature cells in the peripheral blood. And then in that case, we are going to see polychromasia. And then in other case, the presence of nucleated red cells in the blood film. So that is erythroblastemia. So then we'll take a little bit or a look at polychromasia. So when it comes to staining hemoglobin or staining our blood films, we use a stain, the Leishman stain, and that contains eosine and methylene blue. Methylene blue is expected to stain the nuclei, and then the eosine is also expected to stain the hemoglobin. So in polychromasia, you have, a little bit of an excess of the blue staining or the basic dye that is supposed to be, to stain the nuclei of, let's say, any nucleated cell, like the white cells or a nucleated red cell. But in this case, you have the methylene blue also being picked up a bit by the cytoplasm of the red cell. And so when this happens, or when in the presence of this, what information it gives us is that those red cells which are staining blue are most likely to be immature red cells, and they are likely to also be what we call the reticulocytes. And in polychromasia, you might find some cells which are slightly larger than the normal red cells, and they may also be usually round. So if we look over here, you see some like that. All right. And like I did mention earlier, you might come across this situation. I just saw something I quickly want to make reference to. So we can see over here, there's a cell which has a nucleus in it. This is a nucleated red cell. And then these are polychromatic red cells. Okay. So realize that the color of the hemoglobin in them is a bit different from what we see in these other cells. And then we also see that these cells here seem to also stay more deeply. They have lost their central pallor, but then I'll talk about them in reference to another abnormality. So this kind of condition may be seen in situations where the bone marrow is really trying to compensate for anemia. So, for example, when there's bleeding or hemolysis, or in other cases, what we call the extramedullary hematopoiesis. Extramedullary hematopoiesis simply means hematopoiesis that is taking place outside the bone marrow. The bone marrow is the site that has, through creation, has been gazetted to be the site for cell production or blood cell production. However, in this case, you find other organs now producing blood cells. So this may happen in case of myelofibrosis and then other, carcinomas, and also in newborns. Newborns too may tend to show such a blood picture. Then we have erythroblastemia. So this is the presence of nucleated red cells in the blood film. So we see one here, a nucleated red cell. And then these are also nucleated red cells. And like I had mentioned earlier, when red cells mature, they are not expected to have a nucleus. And so if you find red cells with nuclei in the blood film, then it tells you that something is very wrong, something is seriously wrong, and you need to find out exactly what. So these erythroblastemia may be found in conditions such as prematurity. So premature babies may present with something like that. Then people with hemolytic disease of the fetus, the newborn. And then also in a condition we call myelofibrosis, in this case, you have fibrous tissue replacing normal hematopoietic tissue in the bone marrow. And then you also have sickle cell anemia, especially when they are in pain crisis. They may also end up producing, they may end up also producing these erythroblasts in the blood film, mainly because there is severe anemia in sickle cell disease, and and because of the increased destruction of the red cells, the bone marrow tries to compensate, and in doing so, it ends up pushing out as well red cells which still have nuclei in them. Then I did mention basophilic stippling earlier on. That is also called punctate basophilia. So here you have some basophilic granules within the red cell. And when you see them, it tells you that then there's something wrong with the process of red cell production and has to be investigated. So all these conditions, listed here may produce this basophilic stippling. So in case you see basophilic stippling in your blood film, you would need to take your time and investigate to find out, is it thalassemia? Is it megaloblastic anemia? Is it infection? Is it liver disease? Is it lead poisoning? Is it the presence of unstable hemoglobins? Or is it the presence of pyrimidine 5 nucleotidase deficiency? All right. Earlier on, too, I did mention dimorphism, that here you see two distinct populations of red cells in a blood film. So over here, we can see that some of the red cells here are seriously hypochromic, whilst others are also looking highly normochromic, whilst others are highly hypochromic. And then I think that there may be also some polychromasia here. Okay. So in this case, a number of conditions would present or can present with that. So one is sideroblastic anemia, another is iron deficiency anemia on therapy. So when you start to treat someone who is iron deficient, first of all, the old red cells, which are hypochromic and microcytic, will still be there. And then the newer ones being formed as a result of the use of the iron to help with the production of hemoglobin, those cells will come out as being normochromic cells. And then you may also have a case of someone who is anemic and is receiving transfusion. So the patient's own cells, which were severely anemic, will be showing the cells which are hypochromic. And then the new blood being transfused is the one that will be having normal hemoglobinization in it. All right. Then we also have those who may have, more than one nutritional deficiency. So a patient who has both iron deficiency, anemia, and also have vitamin B12 deficiency may also present with this dimorphic blood picture. Then lastly, we want to look at variations in the shape of red cells, as well as inclusion bodies that we might find in red cells. So anytime the red cell leaves the bone marrow into the bloodstream, anything at all can happen to it. And most of the time, if the red cell gets damaged, it may lead to the formation of, varied red cells presenting with different shapes. So you can have spherocytosis, which in this case, the red cells are spherical in shape. You have elliptocytosis, where the red cells look elliptical in shape. Ovalocytosis, the red cells look oval in shape. Then you have fragments of red cell, which we call schistocytes. You may also have that in the blood film. Now, there are other bodies that we may come across in the blood film. So one of them is what we call the Pappenheimer body. Other is a Jolly body. We'll look at them shortly. And then also there are other types of poikilocytes. Some of them are pathognomonic in the sense that if you see a cell which is sickle, nothing should tell you the patient has something another condition apart from sickle cell disease. Then we also have some, shapes that arise as a result of either an intrinsic defect of the red cell, and then sometimes too, it could be an extrinsic, factor, which is causing those deviations in shape of the red cell. So the first one we'll look at is spherocytosis. So a spherocyte is a red cell that looks abnormally round. It is way rounded than a normal red cell. We know our red cells are supposed to be round, but this one, they are abnormally round. And they have a very smooth and regular outline or contour. And you might find this happening in a condition which is hereditary. We call that hereditary spherocytosis. Then you may also have these also being produced when you have conditions that result in the fragmentation of the red cell. So you have immune-mediated fragmentation of red cells, and this may be seen in some types of transfusion reactions. And then sometimes when you have hemolytic disease of the newborn, this might also happen. And then in various autoimmune hemolytic conditions too, that can happen. So the exact mechanism by which some of these spherocytes are formed is not, I would say, is not known thoroughly. But one of it is that when you have an antibody or a protein on the surface of the red cell, which the immune system considers to be foreign, there's an attempt by the macrophages to try and engulf some of these cells. But sometimes the macrophage is actually overwhelmed with, trying to engulf so many things. So it ends up rather disrupting the membrane structure of the red cell. And when that happens, you end up forming a bloated cell, which in this case would appear spherocytic in the blood film. And then we also have some toxins from bacteria that can as well cause you to produce these spherocytes. So within this blood film here, we see some red cells. They look very smooth around. They look unusually round, and then they are filled completely with hemoglobin. You don't see any central pallor. So those are spherocytes. And then if we come up here too, we also see them. They just look so rounded, and the hemoglobin in them is a lot. So one can describe them as even being hyperchromic in this case. Then we have the target cells. So if we look in this blood film, we know that for a normal red cell, there should be a central pallor like this one, a space in the middle which you don't find any hemoglobin. But for a target cell, the central pallor is widened, but in the middle of the central pallor is another, area of hemoglobin. So it looks like a target. That's how come it is called a target. So this is also found in a blood film, but like I told you, this cell is actually a deviation in the shape of the red cell. It has got nothing to do with hemoglobinization. So if you should take an electron micrograph of this cell, that is when you realize that the cell actually looks like a cowbee. It looks like a cowrie. It looks like a cowrie. However, when you stain, morphologically, this is how it rather looks like. So here we describe, if you look at the cell, from an electron micrograph, you can see that this is a cell whose surface area is disproportionately larger than the volume of the cell. And that is why it appears as it is. So you might find this in people with obstructive liver disease, severe iron deficiency anemia, thalassemia, various hemoglobinopathies. And it's quite common in people who have hemoglobin C. And then also in people or persons who have undergone splenectomy. All right. So the next set of cells, we call them ovalocytes. So like their name says it all, they are oval in shape. And these may be formed as a result of a hereditary condition, or it could also be an acquired, shape. May happen during the formation of or the preparation of the film. But the thing is that you just expect to see, so you may just happen to see a few of them like that in a normal blood film. So the problem is when the numbers are actually increasing. But then if you come across them occasionally, there's no cause for alarm. So conditions such as thalassemia major, hereditary ovalocytosis, sickle cell anemia, and megaloblastic anemia may present with these ovalocytes. So when you come across ovalocytes, open your eyes and take your time and investigate more. Then elliptocytes. So again, their name also is easy to tell what they are. So they appear elliptical in shape. And in this case, the length of the cell is twice as, longer than the shorter axis. So we see quite a number of them in here. And then within this film, we also see quite more of them here. So like I said, you may find them in conditions which are hereditary in nature. For example, the hereditary elliptocytosis. You may also come across them in megaloblastic anemia, iron deficiency, thalassemia, as well as myelofibrosis. Then we have the dacryocytes, which we popularly call teardrop cells. And we just call them so because, so because of the way they look either pear-shaped or look like a tear. And usually when there is fibrosis of the bone marrow, that is when you have fibrous tissue taking up space in the bone marrow other than the original, original, shape, pear. A teardrop and a pear may look a bit similar, just that for a teardrop, the end is quite pointed more than you have a pear. Okay. So various conditions that, bring about suppression of the bone marrow. In this case, we are looking at fibrous tissue occupying or displacing hematopoietic tissue. So that could also result in the presence of these teardrop cells. And then, of course, you also do have megaloblastic anemia, iron deficiency, and thalassemia. And then we may also find them in conditions when hemopoiesis is not happening in the bone marrow, but happening elsewhere in other tissue. Next, we have the keratocytes, which we may call bite or horn cell. So these cells particularly have two or more horn-like projections towards one side of the cell. So you can see this one, the cytoplasm, sorry, the membrane seems to be still intact. It's not giving up yet. But over here, part of the membrane is broken, and so you rather have the pointed ends. And usually they are normocytic and normochromic, these bite or horn cells. Sometimes too, they may be smaller in size. And these occur as a result of, when you go and when macrophages attempt to remove Hen's bodies from within a red cell, they end up producing that abnormality. And sometimes that may also happen as a result of mechanical, damage to the red cell whilst in circulation. And so this is particularly common in conditions such as uremia, people who have suffered severe burns, and then sometimes too, it could arise as a result of the effects of EDTA. So it's an EDTA artifact. When you also have liver disease. And then the most common cause is something we call the microangiopathic hemolytic anemia. Micro meaning small, angio referring to blood vessels, and then pathic referring to, a disease state. So we are seeing that there is some hemolysis occurring in, so you are having small red cells. So you are having small blood vessels, that is microangio, and then a disease condition. So this particular situation would cause a lot of red cells to try and squeeze themselves through such small vessels. But then within the vessels are also deposited some fibrin. So the fibrin strands and the mesh now cause mechanical damage to the red cells as they flow through, as they flow through the blood vessel. So we have an example here too. So this one looks slightly different from what we have at the top. We also have the blister cell, blister or helmet cell. So in a way, this looks a little bit like the helmet or the bite cell. So here you have a red cell which has an eccentric halo area. So if you say eccentric, means that halo area, it is towards the, the periphery of the cell. And this is usually as a result of, the cell undergoing some oxidative damage to hemoglobin. And usually the results of oxidative damage to hemoglobin would cause the formation of some inclusion bodies, which macrophages will attempt to remove from the red cell. And in doing so, they end up producing the blister. And why the name the blister cell? And when the blister actually breaks, it forms a helmet. All right. So in what conditions are we likely to come across this blister cell or helmet cell? So again, the same condition that I described earlier. That is the microangiopathy. So the microangiopathy again, could make this happen. Within this blood film here, we can see there's a polychromatic cell at the top here. And there may be other things that we can all discuss. So usually in a single patient, many things can happen. But here our focus is on the blister or the helmet cell. Then we also have mechanical hemolysis, which could be caused by the presence of mechanical heart valves. Then we also have Hen's body hemolytic anemias. In the case of G6PD deficiency and thalassemia, you may have this occurring. So here, there is a little note for us to note that in clinical conditions that Hen's bodies are formed, you are most likely to see many bites and blister cells. Next, we have a phenomenon called schistocytosis. So schistocytosis here is referring to a condition in which you are presented with a lot of fragmented red cells within the blood film. We know the normal size of red cells and the characteristics of the cells, but here you can see some small or smaller sized red cells looking funny. And it is actually because these red cells got fragmented along maybe their journey in the red cell. So these are usually smaller in size, and some of them may present with some, spicules or some spines. And then some of them may be round and usually deeply staining. They stain, so for instance, this one like this is staining deeper than the normal staining, that you find in the red cell. But we are told that schistocytes it's normal to find them in a healthy person. And usually less than 0.1% of red cells are schistocytes. But then if you have these numbers increasing, then it means that something definitely is wrong. So again, you might come across these fragmented red cells in conditions such as disseminated intravascular coagulation, microangiopathic hemolytic anemia, as well as various mechanical hemolytic anemias. Yes, we are talking about fragments. So definitely something mechanical would be, would be suspected to have happened to the red cell for them to fragment in that manner. Then again, we have another poikilocyte, red cell poikilocyte, which we call the stomatocytes. Stomatocytes. Remember from the days of senior high school when you started talking about photosynthesis and describing the leaf, we say that the leaf has an opening through which the carbon dioxide, is absorbed into the plant, and then through which oxygen is also expelled into the surrounding environment. So we refer to those small openings on the surface of the leaf as stomata. So one is stoma, and the many is stomata. So like that's just a plural form of the stoma. So a stoma simply means an opening. And I don't know if any of you can tell me how we call inflammation of the stomach. Here I'll pause a bit. I just want to see if someone can tell us what inflammation of the stomach is called. Adisa, if you can allow anyone who would want to attempt, or you may even use the chat to tell us how we term inflammation of the stomach.
Okay, I can do that. So please, you can unmute if you want to ask a question. You can go ahead.
Yes, I think two people have responded saying it is gastritis. Yes, so that is right. And how do we also call inflammation of the mouth? So you may also type into the chat. All right, great.
Please, I think you can go on because nobody
Yes.
has a question.
Okay, so they've typed in the chat. Yes, so that is stomatitis. Yes, so our mouth is also an opening, so it's also called or referred to as a stoma. So inflammation of the mouth is stomatitis. So yes, talking about stomatocytosis. So here we are referring to red cells that are presenting with, a slit in the middle of the cell, almost looking like a mouth. Okay, looking like a mouth. So that is stomatocytosis. We refer to the cell as a stomatocyte. So these stomatocytes are found, or when found in the blood film, is actually not a normal site. And so we need to investigate what exactly is causing these stomatocytes to appear. So we may find them in people who may be abusing alcohol, and then people who have alcoholic liver disease. And then also, this may also occur as a result of a hereditary condition called hereditary stomatocytosis, or in people with hereditary spherocytosis. And then we may also find it in some people that we call the Rh null phenotype. So we have some individuals who are not expressing the Rh antigens. So we refer to them as the Rh null phenotype. And then it may also be purely artifactual. So it might be as a result of how a sample was handled after it was collected into the preservative. All right. So next here we see a picture of a sea urchin. A sea urchin. So it was from this sea urchin that we gave, or the name echinocyte was also given to these cells that we see down here. So here we are seeing a red cell which is having some evenly spaced, pointed, but rounded projections on their surface. However, this particular condition is reversible. So we say that there is no smoke without fire. Whatever is happening is causing the red cell to assume this abnormal shape. So once that can be solved, or whatever is bringing about this expression is fixed or solved, then we will have this phenomenon disappearing from the blood film. So you might sometimes find these in people who are having a hemolytic anemia, or people with uremia, and then people with pyruvate kinase deficiency. So pyruvate kinase is just one of the enzymes we find in the glycolytic pathway. So people with deficiency of that enzyme may also present with these echinocytes. Then we also have microangiopathic hemolytic anemia, which we have mentioned in about 2 or 3 other conditions earlier. Then people with megaloblastic anemia may as well present with these echinocytes. So the echinocytes are also referred to as Behr cell. BURR. Yes, so that's Behr cell. So either you say echinocytes or you report Behr cells. And it can also be purely an artifact. So you need to be able to examine the film carefully and ask yourself questions. Questions that will help you rule out that what you are seeing is not real, and that there's just artifacts that are being formed as a result of maybe poor storage. Okay, so we still have other deviations of red cells. So over here, we can see some red cells which are having some thorn-like projections. And these projections also seem not to have, the same length. Some of the projections are longer or shorter than others. And even in terms of their thickness and shape too, it's not the same. And aside that, they are not, they are irregularly, distributed on the surface of the cell. And so we call these acanthocytes. So these stone-like projections can be from 3 to 12 in number per a particular red cell. And usually these red cells are smaller in size compared to the normal red cell. And sometimes they have no central pallor, or they may just have a very little central pallor. So over here, like there's this one and this one, you don't see any central pallor. You don't see any central pallor for this one as well. So the problem with acanthocytes is that the red cell membrane have an excess of cholesterol. If you look at the phospholipid bilayer, you realize that the polar heads of the phospholipids are towards the exterior and then the interior part of the cell membrane. But in between, then the hydrophilic tails of the cell membrane, the phospholipid of the cell membrane, points towards the inner part of the membrane. And within the inner part of the membrane is cholesterol. Okay, it's cholesterol. So when there is an excess of this cholesterol in the red cell membrane, it leads to the formation of these acanthocytes. So if you should find a large number of these cells on a blood film, it could point to liver disease. It could also point to someone who has had his or her spleen, removed. And then it can also be as a result of anorexia nervosa and then starvation. And so assuming you see some few acanthocytes in the blood film, you can decide to ask the patient whether the patient has not eaten anything that whole day. And you'll be surprised to know that, okay, it's true, the patient hasn't eaten. And when you don't eat, your body will find ways and means to get energy. Okay. All right. Next is one other poikilocyte, which is fairly known or widely known across the world, which are the sickle cells, also called the panocytes. So these are sickle-shaped cell or boat-shaped red cells that you may find in the blood film. So this one is a classical sickle cell. This is also a classical sickle cell. And then within the blood film, we see other features, other abnormal cells. You can see some target cells. You can see a nucleated red cell and so on and so forth. So these cells, we only will find them in only one condition, and that is sickle cell disease. But sickle cell disease is an umbrella, or is a complex of diseases. But what is common to all these sickle cell diseases is the fact that the individual is having one hemoglobin S gene, either having one in combination with other abnormal hemoglobins, or the patient would have inherited the hemoglobin S homozygously, as in from both parents. And so we have different, genotypes of the disease. Again, we have something we call rouleau formation. So rouleau formation here is, so we can see from the film here, we have this and we also have that. So this is a case where you have red cells, stacking on each other, looking like a stack of coins. And when you come across something like this, be careful. First of all, check which part of the film you are examining. If you are examining in the thick portions of the film, you will see a lot of this. But that is not true, as in that is not what is really happening. In the blood film, we have the area of morphology. That is where you need to examine to establish whether something you saw within the thick portions of the film is actually true or not. So you may have this forming in conditions such as hyperfibrinogenemia. When you have lots of fibrin in the blood, it could lead to, the formation of this rouleau. And then you may also have increased levels of globulins, or when you have increased levels of globulins in the blood, it could also lead to the formation of this rouleau. If we understand the principles of the test we call the erythrocyte sedimentation rate, then it will be, fairly easy for you to understand why hyperglobulinemia and hyperfibrinogenemia would result in rouleau formation. And then the last one is monoclonal gammopathy. So monoclonal gammopathy is when you have abnormal, immunoglobulins in the blood, which may either be of clinical significance or they might be of unknown significance. So an example of one that is of clinical significance is a condition we call multiple myeloma. We also have another called the Waldenstrom's macroglobulinemia. Then we also have a type which is of unknown significance. It doesn't seem to have any consequence on the patient, and we call that monoclonal gammopathy of unknown significance. Okay, so if we see rouleau, we need to establish whether we are dealing with a monoclonal gammopathy of unknown significance or we are dealing with another condition such as multiple myeloma or Waldenstrom's macroglobulinemia. Next, we move on to look at inclusion bodies, red cell inclusion bodies. So the first we'll look at is what we call the Howell-Jolly bodies. Howell-Jolly bodies. So these are, so in this picture, we can see some oval-looking cells, and they are large as well. So these look like macrocytes. So they are oval-looking, and then they are having this round, granule inside. You have another one here, there's one here, and then there's one there. And usually they have the same staining characteristics as the nucleus of the cell. And you may see or come across this in conditions such as post-splenectomy. The spleen acts as a quality officer to check all cells that are passing through the blood. Any cells that the spleen finds to be, to look abnormal, the macrophages within the spleen will try to destroy those cells. And so if you should take away the spleen or you should take out the spleen, it means that these abnormal looking cells will just thrive. They will continue to live. And so once the spleen has been removed, that is post-splenectomy, you might come across some of these cells in the peripheral blood. Now, erythropoiesis or production of red cells is not 100% effective. About 10 to 15% of erythropoiesis is ineffective. Okay, so when the spleen is absent, some of these Howell-Jolly bodies or red cells that contain Howell-Jolly bodies may be found in the peripheral blood, because if the spleen was there and it is functional, then the spleen will take them out and you will not find them in the peripheral blood. And in the same way, you might find them also in megaloblastic anemia. And then finally in splenic atrophy. So apart from removing the spleen too, out of some pathological condition can become atrophied, like it can shrink up. And so in that case, the spleen will not be functional anymore. So sometimes we may refer to something we call functional asplenia. Functional asplenia. All right. The next inclusion body is what we call siderotic granules or Pappenheimer bodies. So here you have red cells that contain some small basophilic. So you can see one here, one there, and then you can see this, but this one is more prominent. You can see one, two over there on this cell. So these are small basophilic granules, usually found towards the periphery of the cell. But these are quite different in, they are quite different in their appearance compared to Woolworth bodies. And like I said, they are even smaller in size than the Woolworth bodies. But interestingly, unlike Woolworth bodies, which are made up of DNA or part of the nucleus, these siderotic granules or Pappenheimer bodies are made up of, they are made up of iron. Okay, they are made up of iron. So iron in the form of hemosiderin is what forms this particular Woolworth bodies. And so you can use the Pearl's Prussian blue stain to demonstrate the presence of these Pappenheimer bodies. And two main conditions that you might find this happening is in, sideroblastic erythropoiesis and then hyposplenism. Hyposplenism. All right. Next is Hens bodies. Hens bodies. So if we look at this stain here, we can see that this is a polychromatic red cell. Okay, it's a polychromatic red cell. But then, and this is a Leishman stain slide, but then if we come down here, the staining type we have here is what we call the supravital staining. So supravital staining is staining that you carry out when the red cells are alive. For Leishman stain slide, one would say that once we fix the cells with methanol, we totally kill the cells. But then for the supravital staining, we stain the red cells when they are still alive. So we actually incubate them at 37 degrees Celsius before we are able to stain for the presence of the Hens bodies. So you may use some examples of supravital stains such as the crystal violet, as well as the new methylene blue, etc., to do that. And then the Hens bodies will appear as, some round, blue precipitates. Now, the Hens body in itself, chemically, is denatured hemoglobin. Denatured hemoglobin. And if we say denatured hemoglobin, we are referring to hemoglobin that, oxyhemoglobin has hemoglobin in the ferrous state, Fe2 plus. And then the methemoglobin has the ion in the ferric state, which is Fe3 plus. So anytime you have hemoglobin levels increasing in the form of the methemoglobin, it could be as a result of some oxidative activity going on, which has overwhelmed the reducing power of the red cell, and so you end up having these Hens bodies forming, but you can only see them when you do supravital staining. All right. So most of the time, we may find these Hens bodies associated with the G6PD deficiency. With G6PD deficiency. The next, which may be about the last inclusion body we are looking at, is what we call the Cabot rings, or the Cabot ring. So if you look at this picture, we can see a certain lining or inclusion within the red cell, which is looking like a figure of 8. So this, you can see that it is staining reddish, like reddish to purple, almost like a thread. And usually you find it in conditions which are, quite bad in terms of the degree. So most of the time in severe anemias, you might come across them. And these are actually remnants of the nuclear membrane. And so it appears as a ring or a figure of 8. So it is something which is not common. Myself personally, I've never come across this Cabot ring in a blood film, but then it's something that you might find in people with megaloblastic anemia or people with any other kind of severe anemia, and then also in lead poisoning, and then in abnormal erythropoiesis, you may come across, you may come across this Cabot ring. Okay, so at this juncture, I would just want to quickly find out if we can identify any red cell abnormalities here. So if Adiza, you may allow any of them to unmute, and then they can speak freely about what they see here on this film.
Okay, I can do that. Yeah, so right now I've allowed participants to be able to unmute themselves. So immediately they unmute, they can speak.
All right.
So whoever wants to speak can just unmute and speak. Or you want me to unmute all of them? I don't think that can be done.
Okay, maybe anyone who wants to speak may raise their hand.
Uh-huh. Then yeah. So someone
Okay,
has their
yeah.
hands raised.
So Mr. Yomik,
You
you
can
may
speak.
speak. Yeah.
Mm.
This I'm seeing a teardrop at the right top corner.
Okay, so I guess this one.
Yes.
Okay. So is there any other that anyone else has seen and want to comment about?
Please, my name is Adams, and I'm also seeing a wider.
Oh, you can go. Oh, meeting.
I'm also seeing a wider pallor of the RBCs. So the something that you can see the middle space is wider in this picture.
Okay. Okay, so you want to say that in terms of the population of the red cells on this film,
Yes.
they are markedly reduced. That's why you have the white spaces in between the cells. Okay, that's a very good observation. Any other in terms of morphology, the sizes, the shapes, the hemoglobinization?
Another prominent one would be varied sizes, anisocytosis.
Okay, so
And
there's
they don't have
isocytosis.
uniform size. And
All right, maybe I'll just take one more and then I'll wrap up here. All right, thank you very much. So in actual fact, we have so many things here. So rightly speaking, the population of red cells on this film is markedly reduced, and that's how come we have a lot of spaces in there. So clearly, this tells us that we are dealing with a case of anemia, because anemia doesn't only deal with the amount of hemoglobin, it also deals with how many red cells are present. And so here we can see that there is a marked reduction in red cell numbers. If you look at a lot of the blood films that I was showing, you could see that at least there were a number of red cells in the blood film. But in this case, you could see that they are markedly reduced. And that's a clear sign of anemia. Secondly, the majority of the cells we have here are hypochromic. They are hypochromic in terms of their hemoglobinization. Aside that too, we have quite a few poikilocytes. So we have a pencil-shaped cell here. We also have a cell, this one looks pear-shaped, this one looks, teardrop-like shape. And then we also have a cell here, which looks like a fragmented red cell. We also have a helmet cell here. We have another fragmented red cell here. So in one way or the other, due to the presence of these fragments, we could say that there could be hemolysis. There could be hemolysis occurring
send that to your neighbor
in this particular patient. Then we also have, anisochromia. If we look at the film, we realize that apart from the hypochromic cells, we have some cells which, at least they are almost nearing normochromia in terms of the amount of hemoglobin.
Your neighbor said it to you, will you say it to yourself now?
Then in terms of the sizes
you will say it better to yourself.
we see variations in the sizes of the red cells. Some
Praise
are
God.
microcytic,
Let's give God a
some
big hand
seem
one more
monocytic.
time.
Then
Word
even in
of our
terms of the
praise.
shape, again, we can see some cells which look elliptical
Hallelujah.
or oval in shape. So it seems this
There are
patient
many
is
people
presenting
who
with
suffer
quite a lot of things. There's
not
also a
for the evil that
stomatocyte
they
here.
do,
Okay.
but for the
So
complaint
in
that they
any
keep.
way, can we suggest any kind
With
of
the way I
diagnosis
suffer.
for this
Now I
patient?
don't know the church of people, they don't have their cast votes. So when you go there, the line.
So may we suggest any diagnosis for this patient? So you might also put something in the chat.
Multitasking the saying it, Master.
May you always find yourself in a good company.
And let's also note that sometimes you may have a
There are
combination
also
of
those who excel,
things happening
not
in
because they are strong,
the patient. All right. So per what we have here, we could say that this patient may be having iron deficiency anemia. Yes, of course, the iron deficiency anemia could also be as a result of a lot of hemolysis. Hemolysis in this case, if it is largely intravascular hemolysis,
keep us well.
it will lead to
I
loss
want to
of
thank God.
iron. And so the patient will end up being iron deficient. If the hemolysis is largely extravascular, then the patient will not end up losing much of the iron. Most of the iron will be successfully recycled for use.
Because I have the privilege to be
and so
in a company.
This patient seems to have quite a number of things.
Amen.
That would
And I'm glad we're
say
happy
that the
that
person
you're
will be
that
having
open as
multiple
well.
pathologies. But then
When
we can say
Lot
here
went
that
with
the
Abraham,
morphology
the Bible says,
it's
and
likely
Lot
the
also,
patient
who went
has
with Abraham,
pronounced
was
iron
blessed.
deficiency anemia.
This
But of course, when it comes to diagnosing iron deficiency anemia, we can't use just the blood film alone. We need to go on and do some chemistries, do the ferrogram to be able to confirm to us that the patient actually is iron deficient. All right. So what I want to say here is that these morphological deviations of the red cells
That's why I'm blessed.
are things that we cannot see
Amen.
if we do
I
not
want to
prepare
thank
blood
God for
films,
God's
stain
servant.
them, and examine. So
Papa, for
being
the
able to
blessing
prepare
that
films and
kept enjoying
staining and
and the
examining
privileges as
also
well,
forms a very key
which is part
part of
standing
our
here
job
this morning.
as medical laboratory
I
scientists.
do believe that
If you
every
want
one
to
of us
just
shall be
stay
blessed
alone with
in
the
the
full
name of
blood count,
Jesus.
there are many things that you will never see
When you
or you
think
never get
of
to encounter.
winning, one of the
And
things
so
that readily comes to mind
I would like
is
to urge all of us that
the race.
as we train ourselves, let's also pay attention to the ability to be able to prepare blood film, stain, and examine and report, because that is going to give us more value or will make us be seen to be more valuable or adding more to what our employers are actually expecting of us.
In 1
So with
Corinthians
that
chapter
much ado, I would like to say thank you very much again to the organizers,
run.
and thank you also
He
for
said, know ye
taking
not
part in this CPD
that
training.
in the race of life everyone in it runneth,
Over
but
to you,
only
Adiza.
one win. He says, so I am called to win. Life in a way is a race into
Why? The question is why. That is very good.
Before
I think
we have just finished mapping the additional ones and prepare the maps and all the data. So
Hello.